The very drugs designed to save lives are slowly losing their power because of the way that we're actually using them. A major new study published in the Lancet Public Health has put India's antibiotic prescribing patterns under the scanner. And the findings are significant as well. The researchers say India is relying far too heavily on powerful watch antibiotics, a particular classification by the WHO. These are broad-spectrum drugs that are meant to be reserved for specific infections where first-line medications or treatment become unlikely to work. And the World Health Organization classifies antibiotics into 3 groups: access, watch, and reserve. Access antibiotics are the first choice of common bacterial infections. Then you've got the watch antibiotics. These are stronger medicines that should be used sparingly. Reserve antibiotics are the last line of defense, kept for life-threatening multi-drug resistant infections. And according to this Lancet study, India's antibiotic use is way out of balance. We're using fewer first-line access antibiotics than recommended, far more watch antibiotics than estimated to be necessary, and surprisingly, little of the reserve category despite carrying one of the world's highest burdens of antimicrobial resistance. The concerns don't end there. National data shows that nearly 3 out of every 4 patients hospitalized receive antibiotics. More than half of those prescriptions are for the watch, the middle category, the watch antibiotics, and only 6% are based on microbiological testing before any treatment is sought out. In many cases, doctors prescribe antibiotics before laboratory confirmation, whilst duplicate prescriptions and excessive use of injectable antibiotics continue to raise various concerns. Now, to be fair, India also faces one of the world's highest burdens of infectious diseases. There's no doubt about that. Doctors often have to begin treatment before test results are available because delays can cost lives. It's a serious matter. So this is not about blaming the physicians or the one that's writing the prescription. There is a habit problem over there. But it's not all about that blame. It is about asking whether our prescribing practices are keeping pace with science, whether diagnostic capacity is strong enough, and whether we are preserving these life-saving medicines for the patients who actually and truly need them. Because if antibiotic resistance continues to rise unchecked, tomorrow's routine infections could become far more difficult and in some cases impossible to treat. So how serious is India's antibiotic resistance problem? Are powerful antibiotics being prescribed too freely? And what can doctors, hospitals, policymakers, and even patients, all of us alike, do to prevent a public health crisis? Let's put those questions to our experts here. Dr. Kanika Sood Sharma, radiation oncologist and director of radiation oncology at Dharamchila Narayana Super Speciality Hospital, is also going to be with us. But ladies and gentlemen, we're also joined here by a doctor joining us from Pennsylvania. We've got Dr. Ravi Godse, physician, MD, Pennsylvania, who's with us on the broadcast. Many thanks, doctor. First and foremost, doctor, your first opinion on this Lancet study. Let's hear it from your mouth. What do you think? What do you make of it?
Yeah, I mean, they are essentially correct. We use them indiscriminately. Even a prime minister tweeted about it 2 months ago, asking people to use it responsibly. But it's sort of hard to fix, because there is no control on the pharmacies. So unless there is enforcement, like you said in the beginning, if you go to a doctor, wait half an hour and pay 500 rupees, you have a reasonable expectation to leave with something. And if that doctor doesn't give it, then another doctor
You're right. You see, what I'm trying to understand is that do we have a prescribing pattern problem here? You have doctors that are probably prescribing that more often than they actually should. And we've said it right in the opening statement as well that we don't want to blame the physician, but there seems to be a little bit of a prescription challenge here. Don't you think so? What do you make of that?
Because the thing is, you need education saying that if it is a virus, even if you take the antibiotic, that's not going to change anything. The antibiotic is going to fix it in 1 week, and without antibiotics, it is going to take 7 days, So somebody needs to tell you that very honestly, without fear of losing business. If I'm in private practice, I'm not going to bother. I'm just going to give you what you want, and I'm going to move on to the next patient, Right? That's the problem, And in India, if the physician doesn't give it, you can get it from a pharmacist, People go to the pharmacist and tell them I have a headache.
That is a pertinent point that you've placed on the table here. But in terms of advisories, in terms of public policy? Is there something more that the government, that the hospitals, that the patients can do? I'll come to the awareness in just a bit, but first and foremost in terms of advisory, because we don't want to create panic, but let's educate the viewers here as well, Dr. Godse.
But the problem in India is, like, some people who are prescribing are not even doctors. We don't know what their degrees are. Pharmacists are giving in without prescription. So we can do a tag code to the antibiotic. So each antibiotic packet, we will know where it is going, who dispensed it. And then we can try and match it with the prescription, whether it was a legal prescription. So it has to be all electronic. Doctor means pushing it on doctors is not going to change anything,
I agree.
It
I
will
agree.
be
That's what
at
we
the
said.
enforcement level, at the level of the pharmacy.
That's what we said. That's what we said ourselves. But Dr. Godse, you see, let's talk about awareness. That's what I was trying to get at. Can we make the patients, make the hospitals a little bit more aware? You're joining us from Pennsylvania. What's it like over there, and what can we actually tell our hospitals and our medical fraternity here back at home?
I think it's very hard to do in India because, I think one of the biggest calamity that India is facing is WhatsApp, because there are so many unverified stories circulating all the time, always somebody's uncle. My uncle went to the doctor, he waited 2 hours, he didn't get the antibiotic, now he's dying in some hospital and this and that. All unverified stories circulating. And, I think it is a little harder to push everything on Indian public, Means I'm a US citizen. To open a bank account in India, I can tell you it is easier to rob a bank, than opening a bank account. There could be so much regulation for a bank account. Why can't there be like some control on the pharmacies? And antibiotics is just the tip of the iceberg. There are way deadlier things like prednisone. Steroids is the deadliest thing that can happen to a patient in the hands of an untrained doctor or anybody prescribing steroid, what we saw during the second wave of COVID, So there has to be some control at the level of the pharmacies, and it has to come from the government. Indian public has about had it, they can't do anything more. Yeah.
Many thanks, Dr. Godse, for taking out the time and speaking to us here on News 9. Very quickly, we also have Dr. Kanika Sood, a radiation oncologist, joining us on the broadcast here. Many thanks, doctor, for taking out the time. You see, we were just in conversation with Dr. Godse. He joined us from Pennsylvania. He said it's actually impossible to create that kind of awareness here in India. And I slightly disagree on that note, notwithstanding all the credible points that Dr. Godse did bring to the table. But how often do you see this, doctor, that, you have people walking in with over-the-counter antibiotics? They're overly dependent on antibiotics. They're using antibiotics from this watch category when they should be, using antibiotics from the access category. And then the problem of the reserve category, we don't even have enough. Your assessment of this Lancet study?
Yeah, so I think firstly, I will clarify that, the awareness in the medical community is very strong. And last year, we had a national alliance, I was part of it, where IMA has brought around 200 plus bodies, like they are representing different fraternities, and we have pledged to stand together and to fight against this AMR resistance by stewardship. So each hospital has its microbiology antibiotic policy, so you have to follow that. But unfortunately, this does not translate when it comes to community. As you rightly said, when patients come to us, they already have self-medicated themselves with different lines of antibiotic. So that is the checkpoint where we are still struggling. The over-the-counter purchase, and now surprisingly, the medications or the antibiotics are also available on your apps where you have no check mechanism. So that is another area which is going to worsen this scenario. So I think some messaging has to go to the community that what wrong will happen if we are consuming antibiotics left, right, and center, irrespective of the the guidance of WHO regarding these watch antibiotics.
You're absolutely right here, doctor. But, in terms of that awareness, of course, medical fraternity, there are several guardrails, and you rightly spoke about all these applications. Let's not be taking names here, but you can simply buy an antibiotic, and there is no check on what it's actually doing to you. If we don't change our course today, what does antibiotic resistance actually look like for an ordinary Indian family 5 or 10 years from now? We've seen cases where there was a simple microbial infection in the lungs, but there was nothing that the doctors could do about it because there was major resistance against all kinds of antibiotics that particular gentleman was taking. Khansi hui, le liya, you had a little bit of a sneezing episode, you took another antibiotic, azithromycin or whatever. I mean, I'm not so well versed, but the idea is that if you eat these like, you know, they're some sort of, you know, toffees, then it's going to bite you in the back later on.
I totally agree on to it. It is not 10 years from now. We are already struggling in the current day as well. You know, when we have patients in the IPD and when we get cultures done, we are finding such variants which have multi-drug resistance. NDM, which is unique to our country, and it is life-threatening. The outcomes are so poor. You know, within my friend circle, parents of 2 of my friends had NDM, and if you Google NDM, the outcomes that you see are very, very bad. And these antibiotic resistance have built up because of our unscrupulous usage of antibiotics. To tell you a little bit, like for example, levofloxacin. So many of people, you know, directly jump to levofloxacin for as an antibiotic that is still simple, 1-day dose, so not very complex. But the microbiologists always tell us not to use levofloxacin upfront. It is a second-line antibiotic for tuberculosis. So we are leaving no options, and these CREs and antibiotic resistance will lead us to problems such that in ICUs we will not have anything to offer. We'll never, as you mentioned, even with minor infections, they may.
But what's the reason here, doctor, that hospitals themselves are becoming too dependent? Because data tells us that, you know, 3 out of 4 hospitalized patients receive antibiotics.
So there is a different set of infections which is called hospital-acquired infections. Particularly patients who are in our IPD for long durations, they pick up bugs from the hospital itself. And these microbes which are running in the hospital tend to be more resistant to the antibiotics. If somebody comes to us from community, then the spectrum of the sensitivity is still better.
Okay.
So any prolonged hospitalization, especially from my field, oncology, our oncology patients are in and out of the hospitals a lot of times.
Yeah.
They are hospitalized often for supportive treatment or for procedures. So these are the areas which are of concern. And
Okay.
of course, the hospital-acquired infections again has been taken very, very seriously. Our hand hygiene weeks are observed to educate the staff, the doctors, that how we can reduce them. So
Okay.
that again is a different vertical on which we all are working. But I think this study just has highlighted the problem which we are facing day in and day out already.
All right, doctor. Before I let you go, before I wrap up this segment, I've got 3 rapid fires for you. What do you think is the biggest culprit here? Is it patients, is it doctors, or is it pharmacies?
So I think the avoidance of meeting a specialist and directly buying medications, that is the over-the-counter, it seems to be a big culprit.
Okay. Should antibiotics
Second,
become
even in
impossible
the
to buy without a valid prescription?
So there should be some prescription. All Schedule H may not, but there has to be a medical
Okay,
prescription
okay. All
to
right.
justify the usage of it.
Well-
Many times patients push us. Khansi ho rahi hai, 3 din ho gaye, please give an antibiotic. There is no sputum. There is no sign of a microbial infection. It may be a common viral, which does not require antibiotic at all. For minor viral ailments, people start taking antibiotics, which is really, really worrisome.
All right. Many thanks, doctor. Many thanks, Dr. Sood, for taking out the time and helping us, put this study into perspective. The Lancet study isn't merely putting numbers on a page. It's holding up a mirror to our healthcare system. And it's high time we pull up our socks, our lifestyles, and our policy priorities on that particular note as well. All right, then, before we wrap up this segment of In Your Interest, another important development, because the centre has made it clear that the E20, ethanol 20 petrol, is not a temporary experiment. It is India's long-term fuel policy. In the parliament, the government has ruled out any proposal to return to ethanol-free petrol and has also clarified that there is no decision at present to increase the ethanol blending beyond 20%. The statement comes amid growing concerns and social media claims that E20 fuel could damage vehicle engines or reduce fuel efficiency. Responding to these concerns, the government has defended the policy, saying the E20 is a safe, it's a clean and a technical